Good evening, and welcome to the SpeakSooner Community Education program, or maybe it's good afternoon, depending on where you may be at this moment. The topic we'll be discussing is facing the challenges of healthcare community decisions, the role of patients, family, and providers. I'm Bernard Bandman, and I'm Executive Director of the Center for Communication and Medicine in Bennington, Vermont. I will be your moderator. For those who are not familiar with the SpeakSooner programs, our mission is to prepare patients facing serious illness and their loved ones for honest and timely conversations with healthcare providers, leading to making decisions about care that honor a person's values, priorities, and goals. This evening's webinar will focus on the challenges that patients, families, and healthcare providers may face in making healthcare decisions, some of which can be very difficult. We will explore how communication can be improved for all concerned. Before we meet the panel, I'd like to take a moment to thank our sponsors. Their support makes it possible to present this educational program. I'd like to read their names. The Alcyon Foundation, Adirondack Health Foundation, Bennington Potters, Concy West, Drs. Allison and Eric Nemi, Dr. Carol Salazar, Dr. Robert and Alice Peslich, DePaula Auto Group, GVH Studio, Jenny Roper, Kathleen Blatz, the Keelan Family Foundation, and Michael Keene. And here's our panel. I'd like to take a moment and actually introduce you to them now. Dr. Zail Berry helped found the Fletcher Allen Healthcare Palliative Care Program, now part of the University of Vermont Medical Center, and served as its director until 2004. She is currently in private practice and teaches at the University of Vermont Medical School. Dr. Stephanie Davidson is a licensed clinical psychologist with more than 20 years of experience supporting individuals and couples as they navigate the challenges with medical diagnoses. Dr. Davidson is the manager of the couples program at City of Hope National Medical Center in Los Angeles. Stephanie is a cancer survivor. Matt Lascalzo is a clinical social worker. He is an American Psycho-Oncology Society Fellow and Professor Emeritus of Supportive Care Medicine at City of Hope National Medical Center. In addition to his work with patients and families, Matt has developed an innovative program to address the toll of loss and grief on healthcare professionals. Pamela Simon, who is on her way, I just got a message from her, she'll be joining us shortly, is a nurse practitioner who launched the Adolescent and Young Adult Cancer Program at Stanford Health in 2015. She continues to work to improve care for this underserved population at a local, regional, and national level. Dr. Fidel Rubagumia was interviewed for this program, and you'll hear his thoughts on oh, there's Pam. Good. She's just joining us now. Okay, good. Dr. Fidel Rubagumia, as I just mentioned, was interviewed for this program, and you'll hear his thoughts on pre-recorded video. It happens to be 3 a.m. in Rwanda. So Dr. Rubagumia is a consulting oncologist and director of research at the Rwanda Military Hospital. He is the first Dartmouth Cancer Center Global Oncology Visiting Research Scholar. We were introduced to Dr. Rubagumia by Dartmouth oncologist Dr. Mary Chamberlain, who has been consulting with the cancer team in Rwanda for over 10 years. So before we begin, just to remind you, everyone, that we'll be taking questions throughout the program, and you can submit these questions through the form you received with the link to your webinar registration, or online through the Q&A on your screen. And we'll answer as many questions as time allows. Now, I want you also to keep in mind that you're about to see recorded videos on Zoom, and they were taken at different locations in the United States and in Rwanda. So there may be a little bit of audio in terms of maybe a little bit low. So if you find that to be the case, just increase the volume on your own device, and that should improve that. So now let's get right to the program. We're going to begin by viewing a video on the challenges to healthcare communication, which is actually going to set the stage for our panel discussion. So let's take a look.
I think a lot of it stems from, well, two main factors. And one is that there's really an imbalance of understanding and information. So doctors are, and sometimes, I mean, we're talking a different language, really. And so there's there's just really, in the most cases, a lack of familiarity with the medical world. And the second piece of this is that these conversations are emotionally charged a lot of the time, especially if we're talking about serious illness, end of life care, that kind of stuff. And when people's emotions are high, their cognitive function really shuts down tremendously. There are many times, I'm sure, that people hear information and the doctor says, well, I told you that before, and they have no memory of it. And it's really, when we're taught to give bad news, you give the shot across the bow and you stop, because the person's not going to take in what you say next.
Much like any provider that works in a healthcare center, a lot of it is around health literacy. So many patients really, this is a brand new language for them. And for our cancer patients, they have been diagnosed with cancer. And for many people, it's a very abrupt shift. I talk about it being like a very quick right-hand turn that they didn't anticipate making. And now they kind of feel lost as they're trying to navigate this new landscape. And so for a lot of folks, it's really about trying to understand what their medical team is saying to them, and then take that information and talk to their loved ones about how to make decisions. What is this going to mean for our life as we move forward? So that becomes very challenging for people to really think through how to ask good questions, how to ask questions that will help them make good decisions, and then how to get the information that they get from their doctors, remember it well enough and understand it well enough to then be able to make decisions from there.
With the couples, though, we often find protective buffering. And protective buffering, especially when it's with the intimate couple, committed couple, that really is a challenge. It can come from the patient or the partner, but when we're talking about buffering, it's usually the partner and or the family who are minimizing or denying concerns that they have, withholding information, and even avoiding having a good argument where they can each emotionally express the intensity of their concerns. Because if you think about it, what greater barrier can there be than the person who you are committed to, the person who you count on most? You can't have an honest, open conversation. That's a tremendous barrier for the patient coping. It's a tremendous barrier for the caregiver, the partner, the family to know what needs to be done and to be able to talk about that they may not know, because this individual is an individual as they are. So it's all about open, honest, courageous communication.
When you throw in being younger as an adolescent or young adult, both sides want to protect each other. And so they may not ask the questions that they have. They may not want to have questions, And so it's really important to try to foster communication from the beginning. I know with a lot of my AYAs, or adolescents and young adults, right away, communication is difficult. Right away, you can already see them pulling back and not wanting to share, either because of their own issues, maybe, being afraid of what might be the case, what they might hear. And like I said, also protecting their family. They don't want their family to suffer. They don't want their family to worry, be anxious. And so I think, especially in the beginning, when the diagnosis is early on, it can be very difficult. I also have times when sometimes parents want to protect their son or daughter and don't want to tell them everything. And I know that comes from, in the heart trying to protect, but actually with an adolescent young adult, of course, it's going to cause issues.
And some of the challenges here, specifically in our settings, is that we are still in era where most of our patients are really not educated. So even if you say about, the whatever medical jargon that you want to throw there, or whatever you want to educate them in terms of, for example, this is stage what, the prognosis is this. Some of them they don't understand. Sometimes you try to make a shared decision making, and what they say, and they always say is, doctor, you are the one who knows what to do. Please take whatever decision you want to take. And it becomes difficult for shared decision making. And then other challenges in terms of communication is that some of the family members want to protect their relatives, and sometimes they come ahead of the patient in the clinic and say, doctor, I don't want you to break the news to my father, to my mother, or whatever relative, or to my son or daughter, because I think when you break the news, they're going to actually die faster.
So you've heard some of what the panel had to say, which really kind of paves the way to really have an expanded discussion about the communication challenges that patients, families, and the providers have in making informed healthcare decisions. So what I'd like to do now is actually, I'm going to begin with you, Dr. Berry, because in the video, you mentioned the disconnect between the language of medicine and what patients and families may understand those words to mean. You also acknowledge a heightened emotional state that can influence what patients understand about their diagnosis, the treatment options, and a prognosis. So can you tell us how this presents a challenge for patients, families, and yourself in the process of making informed healthcare decisions?
Well, I think every member of the panel in the videos sort of acknowledged this, that it does lead to people withholding information, not voicing their concerns, and as everybody else has said, not talking to one another about these things. So it's really hard, and I think the role of the clinician is to pave the way to make it okay to talk about these things, and that's not always easy, but it's I really think that, people can't handle this without us paving the way for them to do it. Again, using all the resources available in terms of, the other members of the team. So it's not always the doctor doing it, but it's important the doctor be on board, frankly, because if the rest of the team has a heck of a time if the doctor's not on board with as I say, shared decision making.
Okay, thanks. I'd like to turn to Dr. Davidson because you come with a dual perspective. As a psychologist and as a cancer survivor, can you tell us what you observed in your work and experience personally about these communication challenges that, again, could influence decisions about care?
Yes, I think there's a lot of challenges that many people brought up in the video. But I think one of the things that I think about is when we work with couples, we think about early intervention and early conversations starting right from the beginning of someone's medical care. And I think that's probably one of the biggest pieces that I felt I was missing in my own experience was this opportunity to have permission for this to be an ongoing conversation about healthcare decisions, about questions that I had. And so I think we have a wonderful opportunity as providers to start early and give people permission to have these conversations as an ongoing discussion where they have opportunities to continue to ask questions, think about what they don't understand, and come back to gain more health literacy over time.
Yeah, I think the challenges, as you both really referenced, it's on a continuum. They continue to be there, you know? And so in this part, we're really honing in on, yeah, they're there at the beginning and they continue to be there. And as things may change, right? It's transitions in care, it can get even more complicated. But let me turn to you, Matt, because you developed a supportive care program for couples at City of Hope. Preceding Stephanie. So I'd like to ask you about the challenges facing patients and their partners in communicating with one another about tough subjects.
Sure. First of all, since we're talking about communication, I want to thank you, Bernie. You and your program have been there for many, many years when there was nothing else out there. And you built it and we use it from coast to coast. I know my colleague Lydia Shapira feels the same way about you. So I want to say thank you, first of all.
Thank you.
And then I'll get to really what you are asking me. I think that the emotionally laden conversations are really socially involved, and that is that we are brought up to evolve to avoid emotionally intense experiences because they can be scary, and the implications can be really a real challenge. If you throw in serious illness now, which is inherently laden with meaning for each individual, the patient, the family, and these meanings are unique to each person. So it's hard to know where you are at any one time unless you're talking about it and unless we create rituals, which we do not have in healthcare. I think that Dr. Berry nailed it when she said people look to the physician to know, am I really in trouble yet? And if that's what we're doing, then we have the cart before the horse. We need to create rituals within the institution to have these kinds of conversations from day one. And I'll share some information later about this, about one way of priming conversations where patients and their partners, which is what the program that Dr. Davidson is running now, with patients and partners are primed from before they even meet with the physician about these conversations. But we have to realize that there's so much fear of abandonment. There's so much guilt over burden put on my partner, my children. And the demands of being ill really can be overwhelming. So when you have all of that, it's not surprising that communication becomes difficult and becomes challenging. But the good news is that it's possible.
Yeah, thanks, Matt. Yeah, it is possible. We're going to talk a lot more about those things later. But let me now turn to Pam. And good to see you, Pam. You made it.
I made it.
Just in time, right? That's a whole other story, actually, that later on when we talk about time pressures in the office.
Yes.
We can discuss that now personally because what delayed you. Okay, so let me ask you, Pam. Can you share your experience again no, I'm getting ahead of myself. Nope. I turned the page too fast. Here we go. You launched, as I said earlier in introduction, the Adolescent and Young Adult Cancer Program, the AYA program at Stanford. So can you tell us what have you found to be the biggest communication challenges with this young population?
Yes, adolescent young adults are defined in the US as 15 to 39. So you can imagine when you think about developmental milestones and things going on between 15 and 39, I think you already see what some of the challenges from communication can be. But I also think that, when it comes to providers, providers often don't feel like they connect with this age group, or can I connect with this population of patients? And so that already sets up a difficult communication when you're going to have to give maybe a really difficult diagnosis or a diagnosis at all, right? So I think it's challenging when we know we have younger patients to talk to about maybe dying, maybe just, a diagnosis of cancer. And I think that it's important to remember that, they are adults per se, and they need to be talked to, but their families are usually around them as well. And so as providers, I think it's really important to remember that we're talking to the patient, even though sometimes it might be easier to talk to the parent or other caregivers for the young adolescents and young adults. But I think that's what I see, is that people just don't feel comfortable with this population.
Yeah, absolutely. And I'd like to actually, pick up where Dr. Rubagumia, what he said in his pre-recorded video, because what he was emphasizing was issues, and actually you brought it up already, Stephanie, about health literacy. And he also brought up cultural issues that can influence decision making. And at the very end, you heard him say that sometimes the family come to him before the patient and they say, don't say anything. Don't say anything, because the cultural belief is that they will die if they have this information. So that's another really nuanced piece to communicating the challenges, right? And by the way, these cultural influences are also present here. And you, especially if you're in more urban areas, you meet with patients and their families, and I think you would find some very similar kind of beliefs about a diagnosis and communicating that with the patient, him or herself. So it's another piece to this first part we're discussing, which is, what are the challenges? What are we really facing here? And so I'm glad we kind of set the stage with that part of our discussion. And just to say, and I really, you all know this, but there are no simple solutions to any of this, right? And whether you're the patient, you're the family member, the provider, and I think too often people throw their arms up in exasperation. It's like, in terms of how can we talk about these? Can we talk about these things? And we have a healthcare system, by the way, that can present obstacles to this as well. And we'll be talking a little bit later about how to navigate it, but that's true, But the point is, with all of you, we are actually going to be talking about what can be done. So with that in mind, I'd like to have us all look at the next video, which really has to do with the experiences that you all have had as providers in terms of navigating these challenges. So let's take a look.
Navigating these challenges, first and foremost, is really to assess what the patient understands. So in most cases, I will sit with a patient first and just say, tell me about what you know from your doctor about what's happening. So in their own words, asking them to tell me what's happening, and then ask them what questions they have. So what are the questions that you have based on your understanding? And then from there, I usually try to give them some context, some language, simplified language to use in asking questions. So if they talk about what their treatment steps are going to look like, I often then will outline, yes, often people will start with surgery. This is what your surgery is called. This is what chemotherapy is called, and this is what chemotherapy entails. It can be any systemic treatment that is given a drug. It can be given in different means. So I try to give them some language and simplify it so that patients can really understand and be able to talk to their loved ones about it. When we're fortunate enough to be able to do this with couples, then they both are able to sit with us and understand the language that we're using that is simplified. And we get a chance to ask them both about their understanding about prognosis.
I do bring up the tough questions and say, you know, have you ever thought about what's important to you in case this doesn't go the way we want? Something like that. And, you know, some people look at me like deer in the headlights and say no. And I say, well, you know, if that's something you'd like to talk about sometime, let me know. And you know, it's rare that somebody doesn't come. I mean, maybe it's not that day, but they come back and say, you know. Another one of my favorite questions is, have any of your doctors given you some idea of what you can expect from here? And, you know, and then if they say no, I say, is that information you'd like to have? And, you know, I never, if I know that it's going to have an emotional impact, I ask for permission. You know, maybe they say, no, I'm not ready for that. But, and at least to let them know that they could get that information if they wanted to.
What I've learned through all these years is that communication is not one event. It's, and the good thing about, not a good thing I would say, but our patients will come to us many times. So I don't take communication as one event. It's not like I'm going to say, this is diagnosis and this is it and this is it, and then that's all. Treating chronic diseases like cancer takes a long time, and sometimes we develop even personal relationship with our patients. So I take it as a process of listening, process of explaining, you know, facts, and also trying to check patients and families' understanding of what I share. And of course, working with patients and their families throughout whatever uncertainties that come along the journey. That's what I've learned along the way. But I try to sometimes check in, as I said, with patients so that I understand what they already know, even their families. What do they know about the diagnosis? What do they know about the treatment? And then once I know what they understand and what matters most to them, of course, I try always to simplify the facts, whatever evidence that I have to share. I avoid too much jargon and try to break information into clear parts, like, you know, from the diagnosis up to treatment, side effect, and all that. So, and then it's always to acknowledge. It's always good to acknowledge the emotions before giving any information. Sometimes I do hold some information in the first clinic, and then probably progressively as we continue to meet and they're open to me, I try to continue to give more information as we go along the journey. So I think it's to me, as I said, it's not a one-day event. It's a process, and that's how I do that.
I think navigating these challenges is a challenge, but I think the more I work with patients and understand that it's very important from the beginning to lay the ground for open communication. Sometimes that means you have to give patients more time or families more time to feel comfortable, but having that conversation with them in some way about the importance of being truthful, about being open, about being a communicator. I think also talking about the unique issues of AYAs is important for them to understand where they're at in their, life as far as an adolescent young adult and how this diagnosis can impact it in unique ways. And so being open and having that communication be open is so important to help prevent some of those issues and make some of that impact less, right? And make sure that there are open lines of communication that both feel comfortable talking about. And, I think also just being open about how uncomfortable it is to talk about this, and that's okay. That it's okay if you don't know what to say or how to say it. The most important thing is that you say it.
One of the ways to get people to start talking about it is priming, and that is having questionnaires that are short, to the point, and important language that people can understand. So when they meet with their healthcare team, the healthcare team knows what they're concerned about. But it also gives the patient and the partner the language that they need. You are thinking you're going to be cured. You are thinking she's going to be gone next week. Let's get accurate information, and that can only come from your treating physician. So let's practice quickly now. Let's practice some of the language you're going to use the next time you want to meet with your physician. We know if I just say, talk to your physician, we know that's less likely to happen. You got to put the tools in their hands, because this is something that really is going to impact everything that this couple does, their perception of the situation.
Well, it's all powerful stuff and very helpful, actually. So let me turn now to the panel. And again, really wanting to have you expand on what you said in the video. And you did cover a lot of territory, each of you. But I'll start with Dr. Davidson, Stephanie. So can you expand on what you said in the video about your experience as a cancer patient and how that has informed your work as a psychologist in helping patients and loved ones navigate the challenges you once faced?
I think the biggest challenge is figuring out how to fill the gaps. I hear all of us in the video talking about the gaps in information that patients have and their loved ones have, trying to understand what do they know, how much do they get about what's happening. And I remember that very, very clearly from my own experience. What I often kind of channel is the feeling of being in those early meetings, thinking that I had some exposure to cancer. I kind of understood a little bit about the field. I run a few support groups, but I understood very little about cancer at that time. That was many years ago. And when I look back at that person that was sitting in that room, trying to take in all of this information that was coming at me and looking at the people that care about me and watching them try to take in all of that information and then walking out of those meetings and then trying to process through all of that, there were a lot of gaps in each one of those meetings. And it took a long time to really understand what was happening and what this was going to mean for the long term of my health and my life as I moved forward, which I was fortunate to do. So I think a lot about how do I help people understand where the gaps in their information is and how can I help them fill those gaps by having early conversations and really preparing for their doctor's appointments in a thoughtful way.
Yeah, good. So let me ask you, Dr. Berry, can you share your experience as a palliative care physician in communicating with patients about options for treatment that may have limited effectiveness and diminish quality of life? Have navigated that one.
Sorry about that. Thank you. I will echo what others have also said about starting early and really introducing the concept of values early on. So even in an introductory, okay, this is cancer, and this is what can happen with this cancer, and you know, in a really basic way, just sort of talking about this is what we hope for, but there's a lot of uncertainty about how well it's going to work. And, you know, I will say, like in a first meeting, I mean, you know, if the person is ready to talk about this, and again, making sure that the emotion is not getting in the way is pretty critical. But if they do seem able to say, you know, it would help me a lot to know what's important to you. And so that we can check in, periodically, and especially at points where we need to make decisions, to have some reference to, as you look forward now, what's important to have in your life, and what's important to you, and maybe even ask, depending upon what they say. I mean, some people look at you like, yeah, no idea what you're talking about. And I said, well, some people would be willing to go through a lot of discomfort to be able to live a little bit longer, and other people wouldn't. They would rather be with their grandkids or whatever. So, sort of giving some examples of, things that people are going to understand. Okay, that's what these trade-offs may look like, and that sort of thing. A couple of other things. One thing is, I have heard from so many patients, that they keep going with the chemo because they don't want to disappoint their physician. And to sort of, we got to get our egos out of this and make sure that our message is, I'm here to support you and to make sure your life is exactly what you want it to be, and to be as best as you can. And, it's not about my life, it's your life. So, I really want to help you. I need to know more about you to be able to do that. And the other thing, we've all talked about asking people what they know. And that can be phrased a lot of different ways. And sometimes I've had patients tell me that they feel put on the spot when someone says, well, tell me what you know about your cancer. And they're like, oh God, I don't remember anything that was said. And it's just really important, again, to say, for me to be able to explain, well, I'd like to know what your understanding is from either from what I've said before or what somebody else has said before. Can you just tell me? And that, the asking and telling, and then after we get through, maybe even asking again, boy, I've given you a lot of things to think about here. Can you help me see if I've been, if you've been able to absorb some of this? Tell me kind of what we've talked about today. Like, what are you going to tell your husband when you get home about what we talked about? Just to phrase it in a way that they can't, there's no wrong answer. They're not, because again, it's, when you feel like you got to answer a test question, your anxiety plugs in, and the rest of it goes away. So anyway, I just think it's really important to establish that kind of neutrality from really early on.
Thanks. So let me ask you, Pam. So can you share your experience in facilitating communication with the AI patients and their families as they navigate the shocking reality of a cancer diagnosis at an early age and the uncertainties about the future?
Yeah, so I think with facilitating communication, I think establishing that trust and rapport, which many people have talked about, is important. And with this population, I don't go in and start talking about the cancer right away, right? I want to know about who they are. What were they doing before all this? What were their goals? What were the things that they wanted to do? And then, meeting them where they are. I think that's another one that, we've talked about parents and caregivers being in the room and all of that. And sometimes, it may be that AYAs have a communication preference that may be more passive or more active, trying to really find out where they're at that moment. It may change too. And I think that's important to know, is that sometimes, it sounds like the parent may answer for them a few times, but as they start to, feel more confident and, like Dr. Davidson said, and Dr. Berry, starting to understand all of these gaps, then maybe they can start making their own decisions and being more in that decision making. But you have to kind of meet them where they are, and that might change each time, which can be more difficult for providers.
Yeah, thanks. Well, Matt, over the years, you've worked with many couples who hold different beliefs about the future. You mentioned it a little bit earlier, right, in the video. So how have you helped them navigate this emotionally charged terrain?
Thank you for asking that. First of all, I would love to be taken care of by everyone on this call. It's so refreshing to hear about the honesty and the courage. So I just want to say that. I think you need to, if we're talking about couples, I believe you need to recognize that there are three entities there. There's the patient, there's the partner, same or opposite sex, and there's the couple. And those are three separate entities that are integrated on really different levels. And I tend to focus on where they agree, not really not their emotions, because emotions are inclinations, not destinations. I don't want them trapped in their emotions. I want them to use their emotions as fuel to work together against this threat. And this threat is a serious illness. And this serious illness will confuse you. And that's why we need to work as a team. So we need to know, first of all, what's their understanding of the situation. And Dr. Davidson, our team, and I, we have come up with a question asking just that of both the patient and the partner. And then we say, well, how far off are you in your understandings? Because you haven't met with the physician yet in many circumstances. And we want you to work together when you go to meet with her or him so you can get on the same page, so we know what we are doing. And this is an opportunity. It's a scary one, but it's an opportunity for you to look back weeks, months, or years from now and be proud of how you held up your part of this relationship. And can we ask you, can you make a commitment to do that today as we are speaking? Are you committed to thinking about how you could be proud of yourself in the future by what you're doing now? And so it's a strengths-based, highly focused, honest conversation. And we can get to other issues later, but in that first session, we need to bond as a threesome and to think about where do we agree, what strengths do each of us have, and what strengths do we have as a couple.
Thank you, really, all what you're all saying. So here's a moment where I really want to, we have some questions coming in, and we want to have those people participating in this. And so I'm going to ask the first question here, and it's related to what you're all talking about, particularly what Matt just said. He says, I'm a 74-year-old with stage 4B prostate cancer, an aggressive cancer that has broken through hormone treatment after 18 months. I've noticed that when my wife attends appointments with my oncologist and nurse practitioner, they are somewhat softer in their communication and convey greater optimism than when I meet with them alone. Part of that is due to my pointed prognostic questions, but I find this troubling in that I want my wife to be psychologically prepared. Have you experienced this dynamic from the clinician side? And I would add, how do you address that? How do you navigate that? And I'll just put that out there to anyone who would like to respond. Anybody? You want to take that one on? Because again, it's back to the couples, and it's back to, but it's also bringing into this equation that the clinician, in this case, it's the oncologist, is delivering, as he says, softer, less frightening information when they go together than when he's there alone. So, I mean, as in your work, clinician, how would you address that with the patient, and how would you advise them in terms of talking to their spouse, right, about this, and then in turn the next step of how are you going to address this with the treating doctor? So, any thoughts about suggestions for this questioner?
Well, I would offer to go with them to their next meeting with the physician. I would not sideswipe the physician. I would let them know that I've invited myself because the patient feels that the information isn't as clear as it could be. I would not go deep into what they're doing wrong or what they're doing right. I would say, let's have a third person in the room with the couple. What what gets me, Bernie, is that you mentioned the couple. They go together, so you're already on third base. And think about how seldom patients come in with their partner. And just having the partner there is a real strength, because now you have the strengths of three entities again, the patient, the partner, and the relationship and the actual couple. I would let the physician know that the patient really needs your support in sharing this information with their partner, because it's so hard and the emotions are so emotionally charged, and we need your help. And if you like, we can talk about what you might want to say to them. And I don't want to insult you saying that a social worker has to tell you how to do that, but we all feel intense about some patients and some couples more than others, and it's not unusual to have countertransference.
Mhm. Yeah. I was thinking too, is for the patient to be able to ask the oncologist for help, right? That I'm really in this dilemma, and share the observation, right? Which really helps that doctor be able to take better care of more than just the disease, because this person's really concerned about his wife dealing psychologically with this advancement of the cancer. So
But
it's
that's a lot to ask of a patient who is already behind the eight ball, who already feels that it's just a lot to put on them. And with some women and men, they're going to do it. You just tell them they're going to do it, and they're going to do it great. But with many people, they're going to need a bit of support.
okay. Yeah.
And my guess is that physician has no idea that they're presenting the information differently. It's completely an unconscious thing going on here.
Yeah. Okay. Well, that's a good question, and some good suggestions in terms of next steps, like what can you do in this situation. So now I'd like to move on to what kind of proactive steps can be taken, and if you've taken and sharing with the people attending about improving communication that can be built into real-time practice. You've shared some of your experiences, including what you do, but in terms of what steps can be taken to improve communication, and we talked about that, and you answered some of these questions in the video. And so let's take a look at the video. And again, on the other side, we'll be able to go a little more deeply into actually very specific approaches that can be, utilized in practice. So let's watch the video on improving healthcare communication.
I would like to see people really bring up these subjects early in terms of signaling, I can talk about this. I want to hear your views about this. Another thing I think is very helpful, a lot of docs now are, the patient comes into the room and they say, I would like to record our conversation to help me write a note later. Is that okay? And I would like to see them say, would you like a recording of this? Because especially when it's one of those big, this is a cancer and this is what the options are, people just don't remember those conversations after the word cancer.
There is a fine line there when it comes to allowing your AYA son or daughter to be able to make these types of decisions. And so it's a learning curve for the parents as well as the AYA. But often this is a time where that AYA needs that independence. They need to feel a part of these decisions. And it will obviously make great decisions it'll make the decisions for the rest of their lives. And so whatever they decide now can impact things in the future for sure. And so decision making is huge in this population, and I don't think that that's something anyone thinks about when they're first diagnosed with cancer, or the parents, that how many decisions have to be made during treatment into survivorship. I mean, you think about survivorship and even just keeping yourself healthy for the rest of your life with all the risks of treatment. I mean, that's huge decision making. Okay, do I take my vitamin D? What if I don't take my vitamin D? What if I don't get my echo? What, you know what I mean? There's so many decisions. And I think the beginning of your diagnosis sets the stage for that as well.
In an ideal world, I would always have the primary caretaker. In our case, we're very fortunate, again, to be able to work with couples. So ideally, I would always have the patient and the primary caretaker that would be with them through most of their treatment, along with them for those early discussions. And that sounds simple, but many people, it's very difficult to get two people in a room out to the hospital to have these discussions with their medical team. So that's one of the things that I always start with is please bring someone with you. I also start with bring a notebook. Let's write down the questions you have as you go in. If I'm fortunate enough to meet with them before they meet with their doctor, we talk about those questions. But at each step in between doctors' meetings, I also have them write down these questions. You won't remember what they are when you get in the room. And I think the other piece is to ask people to reflect on what they learned at each appointment. So to be able to have that discussion, to set up their treatment, to be successful, it's to take in the information, digest the information, and then go back with follow-up questions. I think the follow-up questions is a key element of good communication because people can only take in so much. And because it is such a new language, I think it really does require follow-up questions, follow-up discussions to set their expectations for what treatment is going to look like up to be successful.
When it's time to talk about serious illness, the doctor will bring it up. She or he will bring it up. They'll know to bring it up. They will not know when to bring it up. And we know that when they bring it up, it's too late. It should be done, it being conversations about what's your perception of the medical situation so I can help you understand my perspective as a treating physician. And for them to have that conversation is as crucial as any other, and to have it over a period of time.
So we need to train providers in communication, not just clinical skills. To me, I think as an academician as well, I think that communication should be treated as a core clinical competence, and providers need skills in discussing prognosis, uncertainties, treatment goals, and also how to communicate difficult choices. So these are things that we rarely get trained about in our medical schools, even in in advanced training, but I think that's what we need to do, and we need to make shared decision making the standard, even in settings like ours where it's difficult because patients still give us power, give the doctors power to take decisions. But I think we should make sure that we give the patient and the family a chance to really take decision after hearing what we share as the evidences, and also, and this is I think where SpeakSooner comes in, use patient-friendly tools. These are things that we lack in our settings. We don't have really adapted tools for our settings, and we rarely even use the international ones because, as I said, because of the time pressure that we have. But I think that's what things we need to really start working on: written summaries, diagrams, decision aids, translated materials, and sometimes even follow-up notes for for these patients and families to take, so that they can understand better the diagnosis, and normalize asking questions or being asked questions by our patients and their families as well. So to me, as again, communication does not begin with really better words alone. Begins with, as I said, respect, listening, honesty, and willingness to make care planning truly patient-centered. It's not really paternalistic, it's patient-centered, and there should be shared decision-making.
So you heard what everyone said, and I want to just go back to Dr. Rubagumia, because he referenced something that is, I think, pretty important, and that is training and communication skills, and how he talks about he didn't have any in his medical training, he didn't have any in his advanced training, excuse me, and how really important that is, and needs to be, again, built into the training and education of healthcare professionals. He also referenced, excuse me, the SpeakSooner guide, which we'll talk about a little bit later, which basically, we developed. And again, it's preparing patients, it's giving them prompts, right? It's what you're all talking about. And to help them really identify what their questions and concerns are. It's the encouragement, it's the permission. And in his clinic, it's especially challenging to address any of these issues, again, because of cultural issues. And I say, I want to say this is full disclosure. We are now collaborating with Dr. Rubagumia on a SpeakSooner project in his clinic in Rwanda. He's actually literally working right now on adapting the materials for his patient populations in consideration of what those challenges are. So we're really actually very thrilled to be doing that. So let me ask you, Matt, because you long way back at City of Hope, you developed a very innovative electronic tool to evaluate patient and their loved ones' understanding of prognosis, beginning at the first visit. You referenced it a little bit, but you didn't talk specifically about what this tool actually is and does and how it works. So could you tell us about how it works and how effective it's been?
Well, I could tell you about the tool briefly, and then Dr. Davidson can tell you how her team uses it. That might be helpful.
Mm-hmm.
First of all, my colleague and I, Jim Zabora, when we were at Hopkins, we developed the first screening tool for an outpatient setting. We screened all of the outpatients, and then the tool evolved when we got to UCSD and then City of Hope in terms of it. Then we automated it. And the automation was really crucial because then we could do Spanish, English, and Chinese. 5th to 6th grade reading level, that was a rule. Everything went through patients and their partners in terms of each and every single question. We went into the waiting room and asked objectively, how do you understand this question? We didn't say, this question is about pain. What do you think? It was, how do you understand this question? So we developed Support Screen, which we then licensed. We've done over 50,000 of those screens. And then for the couples program, we needed something to screen the patient and the committed partner, same or opposite sex. And that was all touchscreen. That was on a computer or an iPad. And then we developed an ecological momentary assessment because you could do those 24/7, send questions out 24/7, ask questions. You could put your child's picture on there to motivate you to practice meditation, to take your pain medicine. So all of a sudden, we had a tool that we developed from donor funds to access patients and partners where they are. It's really striking, and then I'll pass this, if it's okay.
Sure, absolutely.
Off to Dr. Davidson. We do have a prognosis question. We have about 3,500 people who have taken it. We have not gotten a single complaint from a patient, partner, or physician. This is before they meet with the treating physician. So they go in to the physician knowing, are the patient and partner in a alignment? And 30% of the time they are not. So it's good to know that. It's good to have that data. And so then Dr. Davidson's team has this to start the process of there are 3 people in the room, and how do we get them to look at their strengths and to move forward? But we prime them by asking them, what's your perception of the medical situation? And 30%, 1 out of 3, that's a high number, are misaligned.
Mhm.
It's, and I just want to add one other thing. I think we ask too much of physicians. We ask too much of patients. We need more support for the human side, because the physicians I know work really, really hard and want to do a great job. The patients want to benefit maximally from their care, but we don't have a system to do that now. You and I talked about this, Bernie. As we shift from healthcare to wealth care, it's only getting harder.
Thank you. Well, let's pass it along to you, Stephanie, in terms of how this program actually works. And go ahead. I'm sorry. Go ahead. I'll toss it to you.
Thank you. I think, it's really about, as Matt said, priming for a deeper conversation. I think, as Matt alluded to, physicians are overwhelmed. They get so little time with their patients. And so when a patient and their partner get into the room, they say, "How are you doing?" They start reporting symptoms. The physician's trying to get through blood work. And so it can become a conversation very much about symptom management, which is important, but it becomes a conversation about a small portion of what's going on for patients and partners. So by asking this question early, it primes us to have a conversation about what is important, what is your understanding of what's happening, and to have a deeper conversation right from the get-go about what the medical situation is, how do we want to manage that together, how do we get on the same page, how do we ask good questions, how do we communicate more effectively with one another and also with our physician. And we continue to ask questions of the patients and partners throughout their time through this ecological momentary assessment, so we can continue to meet them where they are throughout their journey.
Yeah, exactly. Again, the priming, the preparation, continue, and it's built in. That's back to the first piece that I mentioned about building into a system, as opposed to just leaving it up to you to just roll with it. But yes, that's so important. So let me ask you, Pam. You talked a lot about in actually all the videos about the first visit and writing down questions beforehand so the concerns can be prioritized at subsequent visits. And actually, it's the same thing. You're priming the patient and, in this case, the AYA and their family, right? So you're really, in that way, as these similar methods are, it's like really moving the conversation along, but reminding them that they need to be the ones to identify what these concerns are. And again, the priming of this is so critical. So can you just talk a little about how you've seen your approach over time with doing what you're doing in terms of starting at the very first visit and back to them, and use that word again, priming patients to think about their concerns, their questions?
I think that it takes a lot of time to learn this, right? I think, and when I look back over my 35-year, career, I know that I learned most of it from my patients, right? And listening to them and learning what they need, right? Instead of going in there, what do I need to get off, what do I need to tell them, right? What is all the stuff that I need to go through today in my 15-minute appointment or whatever it is? And then over time, what I think I've done is going in there and trying to determine what do they need from me. And how can I communicate that? That might not be everything in one visit. And I might not be able to give everything I want to give in that first visit because it may be too much. And so I think, and the other thing we haven't really mentioned today yet is, the whole digital world. And I think for AYAs, people just assume because they're all electronic that, they want it all electronic. But you got to find out, because I've been so surprised by how when they don't understand something, they need paper or they need visual aids or, and we don't maybe expect that, right? We expect them, they're always on their phone. They're always, right? They're always, doing something on the phone. So trying to really find out, like I said, what do you need from me today? Well, what do you need to help me? And maybe that's just, like I said, it's only going to be one of the things that I had on my, 10 things to tell them. But if that's what they need and they need me to go through that again and explain that again, maybe that's where we are today.
Yeah. Yeah, the digital tools and where information comes from, right?
Yeah, for sure.
So let me just ask you, Zail, because Dr. Rubagumya talked about his experience. He didn't get really training in communication skills. So my question to you has to do with because you're in your teaching, how do you teach young students, medical students or young trainees out of medical school to use a more direct but empathic approach in terms of working with patients to help them understand what they're facing and helping them with decisions about their care? How do you teach that?
Well, we have three wonderful physicians who created a fabulous teaching tool called Vital Talk.
Mm-hmm.
And our medical students at UVM have been doing Vital Talk now for, I want to say, 6 or 7 years.
Mm-hmm.
And the product is amazing. The students are so much more comfortable with emotional conversations. They're much more focused on, connecting with the patient and understanding their world and understanding their understanding. And it's from the time I was trained till not too long ago, the doctor's job was to give information. And so we just wanted to make sure we had all the information, we were up on all the latest stuff. And now these students really understand that their job is to, yes, the information is going to be important, but you're not going to even get there if the person's sobbing and you're not addressing that. And it's not patting their hand and saying they're there, it's okay. No, it's saying, this is really upsetting. What's the worst part for you?
Mm-hmm.
So to say, look, I can deal with this with you. And I have to say, personally, every time I've asked that question, I've got an answer that was completely different than what I expected. And a lot of times it made my job easier. You tell someone they have cancer and they break down and, oh my gosh, and you just think that person's never going to stop crying. And then I say, this is obviously upsetting, but what's the worst part for you? And she said, my daughter's getting married in 6 weeks. Am I going to be there? Oh, of course you're going to be there. It was not like not even a question. So, just exploring, being willing and open to explore what's going on with the patient so that you really can meet their needs.
Yeah. Yeah. It's tools. We're talking a lot about tools, but again, built in. That's the difference. There are a lot of things out there, right? But what you're all talking about is very specific tools that are usable,
right.
And then for the clinicians, in this case, getting a little more comfortable and therefore helping the patients get a little more comfortable, right, in having these conversations. But let me take another question. I know I'm aware of the time. We have a little while, a few more minutes. And this is really a practical one. And I've heard this many, many times where patients get very fearful about talking with their primary care physician or a specialist, all right, about getting a second opinion or a third opinion. And they feel really intimidated. And yet they feel the need to want to get some more information or whatever it is that's going on. So what would you suggest? I mean, in terms of approaching that? Yes, yeah.
I have a dear friend that I had this conversation with a week ago.
Mm-hmm.
And we talked about, and she asked about it, and I said, there is no physician worth their salt who is going to be who's especially an oncologist, who is going to be offended by a second opinion. And, in fact, what happened with this person, her diagnosis was not what was expected. and the physician said, I want you to go to Boston for a second opinion. So, to let them know, first of all, it's not, you really, it's so important for you to understand everything. I also point out when somebody's got 17 members of their family telling them they need to go to Boston, that, second opinions can be very valuable, but they take time and they take usually money and they take a lot of energy. And it would be good to really understand what your goals are for that and whether that trade-off is going to be worth it. Now, some people, especially at the beginning of their diagnosis, they may not even be feeling that bad, but for a lot of people, it's already a place where that's the case. And fortunately, I know her doctor and told her she was in great hands and she had the right person. And then they found out it was a new diagnosis, and indeed she is going at the doctor's behest.
Yeah. I think invariably the doctors will say, fine, it's fine, not be offended. The fear of getting substandard care, right? If you offend your doctor, that. But yeah.
And we're really lucky here. We, our oncologists have great connections with folks at both in Dana-Farber in Boston and Sloan Kettering in New York, and they will often, be on a protocol where, they go periodically down to one of those cities, but then their oncologist here is actually, collaborating with treating that physician and doing the plan together and, as much as possible, so they don't have to leave home.
And I'm thinking again, we're be very sensitive to the time that we've allotted for this for this program. But one of the things that you're all talking about has to do with the communication really has to be a two-way street. And Matt used the word about humanizing, and showing empathy towards one another is really a key to humanizing the relationship and really helping to facilitate the communication. So it's appreciating what everyone is really experiencing. And I thought about time pressures, which is an issue that I was going to kind of dive deeper into, and how you handle that on the heels of Pam feeling the time pressure at her office visit and getting to the webinar. But it really does come down to being able to stop and let that person know, whether you're the physician, being able to say, or the nurse practitioner, recognizing there are certain elements in the visit that may be there, and that we may be able to get to it today, we may not be able to get to it today, but that is determined by a conversation. And that conversation really triggers that there's an appreciation for what each of that person in that dialogue is experiencing, So I think that I really wanted to talk about that, the notion of a two-way street, and appreciating, as you're talking about, what the clinicians are experiencing, and for the clinicians, of course, to really appreciate what the patient has experienced, certainly when they don't have enough time. There's more to say, and there are strategies for that too, but it's just an important piece to all this. And just want to briefly, Matt, do you want to just talk about the project you're working on, and then I'll kind of wrap things up. And that is recognizing that, again, what's being overlooked in terms of the clinician experience and how it actually has an influence on communication is that they often feel a sense of loss and grief in working with very seriously ill patients, and what you're doing, back to what someone is doing to address that. Could you talk a little about your project?
Well, actually, Susan Block and I and Marshall Forstein and Linda Klein co-edited a book on loss and grief in physicians and other healthcare professionals. It took 3 years to get it done, and it was during COVID, but that's not what did it. We got all these proposals. Dr. Block and I put ads in many journals at our own expense, looking for people to tell us their stories of their own losses, not walking in the patient's shoes. We got that, walking in their own shoes. And this happened because of during the AIDS epidemic, one of the chairs with whom I was working said, I give all my time to my patients. I don't have time for my colleagues. And that planted the seed that that's not okay. And so years later, I finally was able to get some ideas together and talk with Oxford Press and say, we need something for doctors, nurses, and others. And so we published the book, and it has 17 chapters, and it's people's stories about their own losses, doctors, nurses, others. And lo and behold, we found it took 3 years because everyone kept sending in these stories about patients, and we kept sending them back. And then 2 of the chapters we had to pull because of legal issues that they could have been vulnerable to. So we pulled those out. So it was a really difficult book to do. I've done 6 other books with Oxford. This was the hardest. It took 3 years. And what we found was for almost all of the authors, and many of these people were from top-notch institutions, some of which you have just named, Zail. And what we found was when it comes to your own loss, the professional veneer is too thin to be helpful. When it's up to your losses, you're just like everyone else, except that you have the intellectual knowledge out there, but it's hard to integrate. So we've turned that into an interactive performance. It's not a play, it's an interactive performance where professional actors read the verbatim scripts and then stop, and then we process this with the audience, which are all healthcare professionals. The next group we are doing this with, Pam, you may care about this. It's with the Oncology Nursing Society on May 15th. We're going to be doing the interactive performance there. But let me just point out one other thing, and then I will stop. 2 or 3 of the top-notch institutions in the country, you know them all, were offered to do this play. And you know what they said? The staff will be so upset they won't be able to function. And if you're going to tell me that these were all men, you'd be right. Gee whiz, I wonder how that happened.
Okay, thank you. Really share that. This topic is a whole program, whole webinar, and maybe we'll talk about that in terms of the experience of the clinicians, and we can get to that. But I'm just, again, aware of the time, and I'm kind of skipping over a lot of what I prepared here. But I did want to just let everybody know who's attending, because we're just so proud and pleased with a program that we've had very much success with. And that is with the SpeakSooner program being integrated into the care of patients at Adirondack Health in Saranac, New York. And there's the guide that we use. And again, it's introduced right at the beginning, and the questions reflected the guide are, as you were talking about, Stephanie, it's like every visit, you reflect on the topics, and it prompts the conversation. It builds stronger relationships. And one of the things that we weren't actually looking at right away, because we were thinking about the patient experience in terms of communication and feeling more satisfied with the care and decisions, was that there was an increase in workplace efficiency with the use of the guide. There was an increase in job satisfaction having these conversations with the staff. And another surprise is we found out that since the SpeakSooner program had been implemented in that hospital, there were 50% less hospitalizations. Huge. I know Matt's had a similar experience at City of Hope in terms of supported care programs. So there's a lot to be said about these kinds of programs, the tools that you've developed and we're working on that really do make a difference. So it can be done. Okay, maybe these major cancer hospitals are not ready to take on your program yet, but it can be done. That's the whole point. And again, I said very early on about the exasperation about, oh my God, there's so much going on, there's so much pressure, so many demands. We really need to recognize that things can be done and will be done. It takes people like you to really move this forward, and it makes a difference. So I thank you all for what you're doing. Again, I'm glossing over some of the questions because we're running over a few minutes. And just to let people know, basically, that if they are interested in Matt's work, you can get in touch with Matt and Stephanie. If you're interested in our work, all you have to do is go to our website, speaksooner.org. And Actually, the Speak Sooner guide is free online. So if anyone would like to access it, it's good. There are guides also, the print guides that are used, again, in the practice itself, which you can also access at our website. So I'm going to try to wrap this up. It's not easy because this is such an interesting, vital, and important conversation, but I need to. I've been told over the years, and actually it's Dr. Shapira told me. She said she'd go like this to me, end it, when we were on the panels together. Okay, so I'm gonna bring it to a close. The one thing I want to just let everybody know, and you'll see there's a slide at the end in terms of contacting us, and you'll also all receive a survey, people who are attending this, and we appreciate if you can complete it because we do like the feedback. And finally, and I always say this because it's so true, and I really believe, of course, and I just said it, the information you've all provided is really so helpful. But I also want to say that communication is not soft or inconsequential. And research suggests that good communication is good medicine and not only helps patients make informed decisions about care, but can also lead, as I just mentioned, and you've had the experience and we've had it at Adirondack Health, to improvement in work efficiency, the satisfaction of the clinicians, and as I noted, even with healthcare costs, which is the big kahuna. So I'd like to thank the panel again for participating. You were great. I'd like to just take a moment and just thank the people behind the scenes because you don't see them, because Louise Payton, who is behind the scenes with all the videos. We also have Meg Cottam and Mike Cutler and Leslie Noyes. These are the folks who you never see, but we really wouldn't be able to put on these programs without them doing their magic. So I'd like to just, again, conclude on behalf of the Center for Communication and Medicine, and there's our guide again, and again, there'll be information at the very end if you want to contact us. There it is. I'd like to thank you all for joining us this evening. And we do look forward to seeing you again at our next Speak Sooner program. And I think to all the things we've talked about tonight, I think we have a lot of material that we could tap into at our next meeting. So thank you all on the panel. Really, thank you, Matt, Stephanie, Zail, and Pam. You were great. And I hope and I really believe that those who are attending it have benefited. And just to keep in mind, a recording of this webinar will be on our website, speaksooner.org, probably in a few days. So if anyone has not been able to attend, you can let them know. They can sign up at our website and be notified by giving us your email, but the recording will live on and it'll always be there. So again, thank you, and everyone have a very good evening.